This is continuation of Lab 2 vitals assessment. This is going into blood pressure. Lab 2, part 1 was looking at heart rate, which was the focus of that particular lab. This one we're going to be looking only at blood pressure. So we're going to look at the definition of terms here, and when we look at blood pressure, this is the measurement of the pulse pressure that's exerted on the walls of the artery. So in the last lab, we were assessing pulse rate and we were feeling for that pulse, and we're counting how many times we felt that pulse. And every time we felt that under our fingers, whether you were at the radial artery or the carotid artery, that was correlated with a contraction of the heart. What we're doing with blood pressure, instead of counting the rate, we're interested in how much pressure is actually being exerted on those vessel walls. And that's measured in this unit of millimeters of mercury, back when the thermometers and pressure gauges used mercury as its fluid, but we don't use that anymore, but we still keep those units. And blood pressure is expressed at 2 points, the systolic pressure and the diastolic pressure, and we'll talk about those in the next slide. So we said that the normal heart rate is between 60 to 100 times per minute at rest. And every time that heart is contracting, it's ejecting a certain amount of blood volume into the circulatory system. It's a pump. Each contraction, it's pushing fluid through, and then each relaxation, it's refilling. And so you're going to have a pressure during contraction and a pressure during relaxation. So that pressure during contraction is the systolic blood pressure. That's the first number that you get when you assess blood pressure. When the heart is relaxing and in between contraction, as it's refilling, there's a residual pressure, and that number is the diastolic pressure. So blood pressure is always expressed in these two values. 120 over 80 is the reference point. That's what we look at as normal. You normally want to be below 120 and below 80. This systolic number, the top number, is the one that gets the most attention. That's going to be the higher of the two, and if this gets too high, it can lead to issues, and we'll talk about those later in the lecture. So just like with the heart rate, there were different values for the size of the individual. You'll see the same thing with blood pressure. The adult blood pressure is 120 over 80, whereas an infant's going to be between 90 and 50. And so just note that in the infants, the smaller the organism, the higher the heart rate, but the lower the blood pressure. As you get larger or older or mature, you have a lower heart rate, but the blood pressure levels tend to increase. So just compare that with the higher or the younger versus the older, or larger versus smaller. And it's really not so much age as it is your mass or your size. Another value that is sometimes used, not in the fitness industry, but in the medical field, is the pulse pressure. And that's basically the difference between the systolic and diastolic. So if you subtract 120 from 80, your pulse pressure is going to be 40. So it's just a differential. We don't use it in the fitness industry, but if you ever see pulse pressure, it's not asking for blood pressure. It's asking for the difference between the systolic and diastolic. Here are your abnormal levels, and you can see that 120 over 80 is considered normal, but really below 120 over 80. Ideally, you want to be, like if you were looking at ultimate health, like 100 for systolic blood pressure. But as we'll explore, that are a lot of factors that affect blood pressure. You can see here that then as we start to go above 120 over 80, like the 120 to 140 and just up to 90, that's considered pre-hypertensive. Now just keep in mind that these readings aren't instant reads and you get one blood pressure reading and that's it. This has to be a trend or a consistent pattern of these blood pressures at these levels for you to end up in these stages. And then you'll see that there's two stages here, stage 1 of hypertensive and stage 2 of hypertensive. And so this gets into the more severe aspect. If someone presents and they're regularly at this 160 or above 150, that's going to be an immediate intervention. If someone is here at this pre-hypertensive stage, they usually try to recommend lifestyle factor changes first. And as we'll talk about with blood pressure itself is a physiological marker, just like your temperature is. It's a vital sign. High blood pressure is a symptom of something else. Just like if you had a thermal regulation problem, let's say your body temperature was 103, you wouldn't think that there was some thermal regulation issue within the brain. It could be, but you're most likely thinking, I have an infection somewhere and my body is trying to ramp up my immune system. So blood pressure is the same thing. When you see elevated levels of blood pressure, it's usually indicative of something else. Let's go back to the body temperature. If your body temperature is, let's say 105, 106, that's a medical emergency. And they don't care why your body temperature is elevated. They're going to do everything they can to bring your temperature down. So you're getting put into a cold bath. You're going to have something, right? Just to bring the temperature down, because that's a medical emergency. As the body gets that hot, things start to shut down, and seizures, and just so with blood pressure, since this is such a risk factor for stroke or for cardiovascular incidences, they don't really care why the blood pressure is elevated. They just need to get it down. That's the intent. The intent is for you, if you came in and you had a regular high blood pressure, they're going to give you some medication. Then, now that the medical emergency or that risk is gone, now you'll start to try to bring that down. Unfortunately, most people don't. They just stay on their medication, their blood pressure gets down low, and they're like, okay, things are fine, right? But just remember that blood pressure and this disease of hypertension and blood pressure is nothing more than equivalent to someone having a high temperature and not finding the source for it. So it truly is a lifestyle aspect. And this is, as we'll talk about, due to certain stresses or different chemical or different stimuli that the heart is being exposed to. How we assess blood pressure, again, we have direct and indirect assessment. Direct assessments are usually done with like post-cardiac surgery. This is where they're introducing a balloon or a little device into the artery so they can measure pressure. Someone had like an aneurysm and they did a vascular repair and they wanted to make sure they kept the blood vessels as pristine as possible to allow them to heal. They're going to really want to control blood pressure and keep blood pressure as low as possible so you don't rupture that vessel. All of the blood pressure assessment that we'll be doing and most medical aspects are doing are non-invasive and indirect. You can do palpation, but the most popular is the auscultation, where you're actually listening for sounds in conjunction with a sphygmometer, which is a blood pressure cuff. So these are the two devices that you need. You need the stethoscope, which you should be familiar with. This is the device that you put in your ears and you can listen better. And then the sphygmometer, this is the blood pressure cuff. Now, you get extra points if you can spell this and say this fast, but you mostly will just refer to it as the blood pressure cuff. So that's what these look like here. There's your stethoscope. These ends go into your ear. There's believe it or not, there's an actual technical way that these are supposed to be worn. If you wear them backwards, you're not going to hear a darn thing. If you hear them right, you're going to hear everything, maybe too much. We'll go over the use of this in lab on Thursday before we actually do the lab. And then you have the sphygmometer here, and you'll see that there's the cuff. You can see that there's an adult size to it. You have a bulb that you use to inflate, a valve to close or open, and then you have your gauge over here. And why blood pressure is somewhat complicated is because you have a lot of things going on. You're trying to listen, you're holding this, you got to make sure this is on the patient's arm, you're supporting the patient's arm, you have to make sure this is in view, and you are deflating at a decent rate, and then trying to listen intently to when sounds start and go away. So this is your equipment. It looks very simple, but it's going to be a juggling act trying to get this down for your first couple of tries. Blood pressure, just like with pulse rates, there's different places that we can be assessed. The brachial artery is the most common, as long as the patient's arm is capable. Sometimes there might be a dialysis port or vascular surgery or injury, and you might not be able to take it. You usually go first. You try to do the other side, and if you can't, you have to go somewhere else. Radial pulse is pretty common. If someone is obese and they have large arms and the cuff won't fit, radial pulse can also work. The leg and the thigh usually done for infants or toddlers, but in the end, the setup is basically the same. You have this cuff on the arm, you have the stethoscope just below it, and then you have the visual aspect. This guy should be looking at the device over here, but you want to make sure it's in the proper alignment. But this right here is a picture-perfect setup for blood pressure assessment. Basically what you're doing is the blood pressure cuff acts as a tourniquet. You are, in essence, squeezing that as it inflates, and you are stopping blood flow. like it's cut off. And if you kept the blood pressure cuff on long enough, you would start to get uncomfortable. You get some tingliness down the hand, and you start to get some color changes. That's why we try to do blood pressure within 60 to 90 seconds, and we try not to do repetitive measures on the same arm. This auscultation one is the one that we're going to be doing. It's one that we use all the time, and it's used in all most medical facilities. So the exact same setup. You have the blood pressure cuff. You're not palpating or finding a pulse this time. But what you're doing is you're putting the head of the stethoscope right here. And what the stethoscope is doing is you're going to pump it up, and you should hear absolutely nothing. And then what you're going to do is you're going to eventually, or you're going to slowly, not too slow, but you're going to slowly release the valve. And as you start to relieve pressure, the pressure within the blood vessel is going to be greater and overcome the pressure of the cuff. And as this blood flow starts coming down the pipe, down the blood vessel, it's not going to be laminar flow. It's going to be like turbulence and currents, and you're like a rapids, if you will, in a river. And it's going to be bouncing against the wall, and you're going to hear sounds. So once you start hearing the sound, you know that the dam broke and that blood is going through. That's the first instance of sound, is your systolic blood pressure. And then once the pressure is normalized and the blood vessel is fully filled, the sound will go away. That is your diastolic blood pressure. So I love this image. It's an old image, but it shows a cross-section of what's going on. And I think the next image I have here kind of shows you what's going on here, is that when you have this fully closed, there's no sound. As the artery just starts to open, you're going to start hearing sounds. So that's your systolic blood pressure. And then once the sounds go away, that's your diastolic blood pressure. So that's what's tricky about this whole setup, is that you're trying to time it so this releases at a slow enough pace, but not too slow. You're listening, and you're trying to correlate the onset and reduction of the sounds based on what you see on the valve. So a lot going on. It is a simple process and simple mechanics and simple thought process behind it, but it does just take a little bit to get used to. These right here are the 4 most common aspects of where air is introduced and why blood pressure makes things difficult. There are in our labs, I think we only have 3 sizes, but there are different sizes here. You have a child, you have small adult, large adult, adult thigh, or severely large, obese. But the right cuff size, it should be able to fit on appropriately. And if it's too big, it's going to underestimate, and if it's too small, it's going to overestimate. The position of the patient is key, making sure that they are either sitting, standing, or lying down. Each one has different blood pressure outcomes, and then the arm, or the site at which you're doing the blood pressure, should be at the exact same level of the heart, just for consistency. A lot of times, especially early on, it's just a Goldilocks principle component again, where too much, too little. You want to be about 20 to 30 millimeters of mercury above expected. Or initially at 200 just to see. But if you start too soon, you don't get enough time for the blood flow to go. And if you go too high, you're going to be keeping that tourniquet on there too long. And then this is the biggest aspect here. And I have a couple YouTube videos posted through Blackboard that can kind of show you the speed at which you should be doing. You want to release this pretty slowly. Again, you want to try to have your complete reading done within 10 seconds, but you don't want to do super fast and do it in 2 seconds or you'll miss it. So as you see the video and you play around, you can see that it's not too slow and not too fast. So when you have these cuffs on there, you're going to be listening, and just remember, you're not going to hear anything right away. I have many times where students put the stethoscope on there and they're trying to listen, and I can't hear anything, I can't get started yet. It's perfect. You're not going to hear anything. Whether the cuff's fully inflated or not inflated, those are the 2 aspects where you're going to hear absolute silence. The only time you're going to hear sounds is when it's turbulent blood flow, when there's a lot of rapids going on because the blood flow is coming through because it's been blocked. So once it's blocked, you're not going to hear anything, or once it's fully open, you're not going to hear anything. So once you start to release that pressure valve, blood's going to start coming through. Once you listen, the doctor who discovered this or set this up, Kordakoff, it's named after him. So these are Kordakoff sounds, and they usually use just the first initial, so K1, K2, K3, but it doesn't matter what the sound is named. It's just, do you hear it or you don't hear it? So you have the 5 phases, K1 through 5. And when you K1 and K5 at the initial tapping, and then as the sounds, after the sounds disappear, those are the 2 numbers you look for. So all these like K2, K3, K4, unless you're some researcher, I have no idea why you're going to want to identify those, but it just sets the tone that you're going to hear a gradual increase in sounds and then a gradual decrease, and it doesn't matter. It's at the first instance of hearing a sound, you're going to mark that, and that's going to be your systolic pressure. And then once the sounds completely go away, you're going to make a mental note of that, and that you're going to record that as your diastolic. So we'll practice this and go through it, but if this sounds simple, it is. If it sounds too complex, you're thinking about it too much, just if you have your setup and you're going to hear nothing, you're going to start releasing the pressure valve, and the numbers are going to start dropping: 200, 199, 198, 197, 196, and it's going to keep on going down, eventually get to like 120. And then all of a sudden you're going to hear silence, and then you're going to start hearing sounds at 125. That's your number. And then it's going to go 125, 120, 115, down to, let's say, 85, and the sounds completely disappear. You mark 85. These are the common errors which are related to the 4 things that I showed earlier: the setup, the wrong cuff size, applying the cuff incorrectly. There's a specific way that it has to go on. Not putting the stethoscope in the right spot, and then messing around with the sounds, making it more complicated than it needs to be. This is a big aspect with this extraneous noise. It's as you get used to setting up the cuff and getting people going, you'll be aware of how your lines are crossing and where you're placing your hands, and it's just getting familiar with the juggling act. Like I said at the beginning, there's a lot of moving parts. Once you get used to that, and that's why we practice this quite a bit, you're pretty set. And then you will practice with the patient position and the equipment you'll just get comfortable with. So as I said, the patient position or the client position matters. So as you change positions, like going from a lying position to a seated position to a standing position, you're putting the heart and the vascular system under different demands of gravity. When you're lying down, all the blood flow, you're horizontal, gravity is perpendicular to you, so it doesn't matter. You're getting adequate blood flow to your head. Once you go from a seated position to a standing position, you are putting your body in a vertical aspect, and now gravity is pulling all the blood down away from the head, and the body has to compensate by changing its pressure and its vascularity, vascular diameters. So blood pressure done in a seated position versus a lying position are going to vary. So you can't compare blood pressure to someone lying down to that same person sitting or standing. You got to compare apples to apples and make sure that you are doing that. This blood pressure aspect we'll talk about in KIN 230. We look at why people faint after long duration events and why cool downs are important. It's because blood vessels have dilated, and for exercise, once exercise is over and you stop, blood just drops from your head and you faint, so your body can get you horizontal as quickly as possible. Blood pressure is such a big deal, and it's such a big issue because it's referred to as the silent killer. And unlike like heart palpitations or a fever, a lot of times you can have high blood pressure and you have no idea. Like if you could be sitting there, like when you have a temperature, you kind of know when your heart is racing, but you have no idea if your blood pressure is 200 or 100, right? Low blood pressure, hypotension, can be symptomatic where you have dizziness or lightheadedness, kind of like why you're fainting or you're not getting enough blood flow to the brain. But hypertension, you don't really feel that until it's like in the 250s, 260s. And even then, some people are totally oblivious to it. So, I have a headache or I have some pressure in my ears. Your blood pressure normally elevates with exercise, but at rest, it should be at these lower levels. You can't feel it. So when you look at the middle number here, that middle sentence, the primary factor, 68% of heart attacks and 75% of strokes, CVAs, which are number 1 and number 3 killers of people in the United States. And so that's why hypertension and controlling hypertension is a big part of that. Now, it's not because blood pressure is elevated, like we've talked about with obesity. Sometimes it's the factors that led to the inflammation in the obese state. Same thing with the high blood pressure. The lifestyle factors or the poor decisions or the low tolerance, the weakness, that's why the blood pressure is elevated. That's why you're at higher risk of heart attack and stroke. So if you do the lifestyle components and the decisions, the diet, the nutrition, the exercise to lower the blood pressure, inadvertently, it's not so much the blood pressure that is the issue. It was the factors leading to the high blood pressure that led to the heart attacks and the strokes. So hypertension is one of the modifiable risk factors. Just like diabetes and metabolism, hypertension is purely lifestyle. You don't need medication for it. There's not a genetic aspect for it. Now, you could be genetically more prone to stress in different aspects, but it's not a primary disease. It's a secondary disease. It's a symptom of something else. But since it is such a risky component where that pressure in the blood vessel could dislodge some material and then create ischemia or block, or it can rupture a blood vessel, this is why it's important to control it and why it's important to check it. So the condition of hypertension is a diagnosed aspect. So there's a difference between having high blood pressure and having hypertension. High blood pressure is you have a random reading that your blood pressure was above 120/80. Hypertension is the actual diagnosed disease state that you have a pattern or a regular finding of hypertension. If you're not a doctor, you can't make that diagnosis. And the reason why is that just because you have this objective view of hypertension saying that you have to have 140/90, at least 2 consecutive readings separated by 1 day, yeah, that's a technical textbook aspect, but it still has to be done within clinical context. It still has to be, there still has to be some discretion made by the physician. Let's say I remember having a student at UIC who was he was in the military. He was a Marine, young guy, super fit. He's still fit. He's an exercise freak, eats well, and he regularly had his blood pressure 190/90. That was just his normal aspect. No one understood why. Could have been like traumatic stress or post-traumatic stress from the military, but in all other aspects, he was a beast. He was healthy. All of his blood markers, his cholesterol levels were low. They even did some heart scans, and he's fine. So for whatever reason, the resting tone nervous system of his body, his blood pressure was 190. That's considered a freak accident waiting to happen. But since he was 19 years old or 20 years old, and he was fit, the doctor determined clinically, based on clinical context, that he's not a candidate. He doesn't need to be on medication. So he just controlled it because of his lifestyle factors. So hypertension is the diagnosed condition. It has to be done by a physician who can take the data and create that clinical picture. You can, when we're doing our fitness assessment, you may find on a regular basis, let's say you take your client's blood pressure and it is like 175. You're like, oh, let's take it again next time we meet, and it's 175 again. What you're going to tell them is that, hey, you know what? It looks like you have high blood pressure. Our readings are on the high end. You should go talk to your physician and find out what's going on, right? And let them make that determination. So you can inform people that their blood pressure readings are high. You can't tell them that they have hypertension. You can look at the risk factors there for associated with hypertension. And again, these are all lifestyle components. So the opposite of hypertension is hypotension. This is when you get pressures that are below 100 or 110. This is not an uncommon finding. It's actually quite common. Remember, the smaller you are, the less blood you have to distribute and the less you have to overcome gravity. Your body mass is lower, so your heart doesn't have to contract as hard. So we find this a lot in smaller, petite individuals, children. It can be an issue. Unlike hypertension, hypotension does have some symptoms associated with it. It's usually because there's not enough blood flow going to the brain. If the body ever feels like there's not enough blood flow going to the brain, it's going to get you horizontal as quickly as possible. So you're going to start to faint. You might faint, and that's what syncope is some kind of fainting spell. But you're going to get some distortion in vision. You're going to start getting that tunnel vision, and you're going to start to pass out. This is usually due to medications, could be trauma, can be infection, blood loss. It's not an uncommon thing. This orthostatic hypotension, it's related to what I was talking about earlier with the sitting versus standing versus seated. This is very common in elderly patients or sick patients or weak patients, people that are sedentary. When you go through the process of working out, your heart rate's increasing. The contractility of the heart is increasing. Pressures are changing. Your body is getting used to these severe changes in environment. So you can go from rest to running to sprint and back to rest again. And your body went from 120/80 to almost 200/100 back down to 120/80 within a 20-minute time frame. Your body has gotten used to the adjustments. If you're sedentary, you're not doing things, what can happen is you can be laying down, you're sleeping, taking a nap, you're there sleeping for 8 hours, hopefully. You get up and you've been horizontal that entire time. You go to change from a seated. How long does it take you to get out of bed? Like within 30 seconds, you're going from supine to standing. That could be enough change where the body doesn't have enough time to adapt, and blood flow drops down to the feet, and your body freaks out and says, "We need to get you horizontal," and you faint. This orthostatic hypotension is a major cause of people coming to the hospital with hip fractures from falls. So be aware of this, particularly if someone is, where this happens a lot with athletes, because if you look at the next slide, this is what causes hypotension, dehydration. When you have these athletes that are weight restricted, so wrestlers, weightlifters, fighters, a lot of times they will try to cut weight and they become dehydrated, and they'll have symptoms of hypotension. Their blood vessels will drop down. So again, hypertension is the silent killer because it's asymptomatic. You don't know when you have hypertension. Hypotension is symptomatic and only an issue if you have symptoms. So if you take someone's blood pressure and it's 90/70, and they're like, "No, I feel great. I feel fine. I can move around," it's probably fine. If they're 100/80 and they say, "I feel a little lightheaded, feel a little woozy," there's something going on. Get them horizontal. Have them lay down in a controlled manner instead of the body doing it on itself. You want to avoid any type of stimulants or depressants. Remember, the heart is sensitive to its environment. It's a window to the stress, and that doesn't affect only heart rate, but also the force of contraction. You want to make sure your feet are on the floor, no dangling. These are some of the technical aspects that we'll go over in class, but these are things that are part of the lab procedures. And then the determinants of blood pressure, we're looking at, again, it's a window to stress. The pump and action of the heart, so the heart rate will affect blood pressure. The vascular tone from the nervous system controls the blood vessel dilation. So in flight or flight type responses, you're going to get constriction of blood vessels, so when you're stressed out. And in parasympathetic, the rest and recover, you're going to get dilation, so blood flow is going to be able to be better. The blood volume, which is related to the fluid in the blood, which is the dehydration, or blood loss. Sometimes with the hypotension, you can have a patient or client that has internal bleeding. Again, you're probably not going to be seeing those type of people in the gym unless they had someone squatted and the bar fell on them and they wanted to work out again. But you're probably going to deal more dehydration than blood loss. And then blood viscosity, in terms of, are they taking aspirin? Are they taking some kind of blood thinner, which it's common, a lot of people are? Is there some condition where they have a thickening of blood pellets, right? So these are some of the aspects that are going to determine blood pressure, and just things to be aware of. But that's it for blood pressure. So what we'll do in lab is we'll go over we'll do some of the setups, and there'll be some videos posted of the technical setups, like where the cuff should go, and these will be that you could use for reference.